Hello and welcome to the HMA Carrick Data Teams training on Data Dictionary 2.0 implementation, lessons from Q1 2025. This recording has been broken up into two sections. This recording you're watching now features a panelist presentation from 4 excellent Cohort 1 and 2 County Carrick Data team members. The second separate recording includes a presentation from the HMA Carrick Data team on data quality information relating to the Q1 2025 Carrick Data submission. Let's turn to our live panelist presentation and live interactive Q&A session now.
But I really want to take this opportunity to facilitate a discussion with 4 counties who were selected from both Cohort 1 as well as Cohort 2 to represent a range of experience in care implementation and data reporting. And so you see our 4 guest speakers here today who have very graciously joined us to share their experiences and to share strategies that they have found useful in reporting data to DHCS. So I'm going to actually ask our panelists to introduce themselves and their role when we get to the point of the discussion. But to kick us off and to kind of frame up our discussion, I wanted to share some data so that we can reflect, I think, collectively on what this means and what supports counties may need as you're working with the revised data dictionary, which have expanded significantly so that we can, hopefully provide the support you need so that you can more do the best job that you can in demonstrating what your counties are doing to support care implementation. So with that, you can see on this slide here, so this is actually, based on the data modules from the Data Dictionary 2.0. So we wanted to share that, in beginning, as you all know, beginning in 2025 of this year, counties are now expected to report on 3 different types of data. So previously, you all were on the hook for reporting on petitioned individuals. But at the beginning of this year, the reporting requirements now includes your efforts in fielding care inquiries as well as systems referrals. So as experts of your own data, we're really hoping that you could help us understand what some of your reporting challenges are, and some help us understand what we're seeing in the reporting from various counties to date. So you'll see 3 sets of bar charts here, right? So these bar charts essentially show the status of data reporting for the first quarter of 2025. And each bar here is broken out by counties. But they're broken out in 3 different sections. So by counties with no data to report, so the gray section, counties with data to report, the light blue section, and counties who did not submit any data for that particular module of the data dictionary, and those are in the navy blue. So if you look at the petitioned individuals chart on the left, by the end of the first quarter of 2025, almost all Cohort 1 counties reported on petitioned individuals, and the one anomaly had a very good reason, which for not being able to report on petitioned individuals. But what we also see is for Cohort 2, who started implementing later, a third of the Cohort 2 counties reported that they had no petitions at the end of the first quarter of 2025. And then if you look at the middle chart on the slide, what you see here is data on care inquiries. So we have one Cohort 1 county who said they had no data to report on care inquiries. And about half of Cohort 2 counties told us that they had no care inquiries. Similarly, if you move across to the third section of the slide to the far right, when it comes to systems referrals, a quarter of Cohort 1 counties told us that you had no system referrals to report, and over 2/3 of Cohort 2 reported they had no systems referral to reports. And so, looking at this, the general observation from our standpoint, and really welcome your input, is that counties with no data to report, the gray section that you see right, in a slide were disproportionately from the more recently implementing care counties. So this suggests that perhaps it's experience with care implementation, perhaps experience with data submission, or other reasons that we're trying to understand, maybe contributing to the picture that we're seeing here. So we'll like folks to really share what may be contributing to what we're seeing here with counties saying that they have no data to report on care inquiries or no data to report on system referrals. So as you're reflecting on this, we've also asked our panelists to reflect on a few key questions and where possible to comment on what we may be seeing on this slide and to help us hypothesize how we can understand better what counties challenges are in reporting data on these different modules. So let's turn to our special guests today to hear from them. So if you go to the next slide, and I see folks, Samantha already popping some hypotheses there, so thank you for that. Folks should continue to pop them in. So I wanted to actually kick off our panelist discussion today. We have three broad questions for each of our panelists. And we're going to take a round robin format for the panel discussion here. And we're going to start with the very first question with our cohort one folks, starting from Matthew from Orange County. And I'm going to invite Matthew to introduce himself. And this is the same for each of the panelists. If you could introduce yourself, tell us what county you're from, your role within the care team, and specifically on how you're managing data in the context of your care team operations within your county. And so the first question that we have here is, in addition to giving us some context about your role, can you also describe your county's processes or workflows that support care data reporting? So Matthew, Carly has posted the question in the chat for folks so that you can follow, but I'd like to invite Matthew to share his observations and his experience. Go ahead, Matthew.
Hi, everyone. I'm Matthew Miltimore. I am an applications developer for data analytics and evaluation at Orange County Behavioral Health Services. So my role within CareCourt is to, I helped with sort of creating the data collection tools we use, but now my focus is on getting the data ready for submission to HMA, as well as any sort of internal data requests we might have related to the care data. So for the first question, I think I'll start by just kind of describing the system we have set up in Orange County to collect and then use the care data. We decided pretty early on that we wanted to have a digital data entry application for the care data. And we wanted that because the data requires us to go back for individual clients and complete multiple surveys for one individual. So we wanted to be able to sort of access the older data for a client easily. And we thought that a data entry application would be the best way to do that. So I created the prototype for that application, and then we passed it off to a vendor we've used before in Orange County called Chorus, and then they created the production version of that application. Yeah, but that took a little bit of time. So for the first few months of CareCourt, we were relying on paper forms, or I guess more accurately, like form-filled PDFs. Yeah, and in terms of sort of staffing and the sort of organizational structure of CareCourt here in Orange County, that's a little bit harder for me to speak to just because my role is pretty narrowly focused on the data side of it. But what I can say is that in Orange County, we have a forensics division, and they have a care team within that division. And they're the ones who are going to CareCourt, doing the outreach, and they're the ones actually completing the surveys within the data entry application. And then I and a few other people on the data analytics team are the ones who are taking the data from that application and transforming it into the format that we need for submission, and then for anything else that we might need to use the data for.
Great, thanks so much, Matthew. And so next, let's turn to Susanna from Riverside.
Yes, I can unmute. My name's Susanna Warris Williamson. I work for Riverside County. I'm an admin services manager in the evaluations unit, and I'm responsible for ensuring our submission is in and on time. I have a research specialist to staff that works on this project. She has other projects as well, but she does a lot of work, training and the data collection work, and both of us really participate in that. So one of the resources we've done is just dedicating staff to work with our care court team, because we have a team that works through a team of care court staff that are working through the court processes and the petitions and making sure they get into the services and our larger service array. So we work very, very closely with them and keep a very open communication. My staff, Sonar Adreshna, talks to them pretty regularly. And initially, we did go through the data dictionary, determine what we had available in our electronic health record, leverage that, and then we built specific forms within our electronic health record to collect the rest of the data. So we did an initial care petition form that collects everything that we need to understand what's going on in their petition and their status. And then we did a monthly check-in form that gives us updates on data that we would need monthly. And that helped us get through, version 1 of the data dictionary. When version 2 came out, we had to comb through that again, make some adjustments to our forms, make adjustments to our query that we use to pull out the data and put the data into the file format for submission. We had already had a process. We were kind of lucky in that sense that we already had a process for inquiries, for care court inquiries, because those were routed initially through our care access line. So we have an access line. That's where we advertise for inquiries to come through, and they use a log anyway for logging calls that come in. And so we use that data to look at care inquiries. If the inquiry is really deep, that access team actually does what we call an integrated referral form that in our electronic health record that goes straight to the care court team for them to call them back, work out what do they need? Do we need to do a petition? So we already had a process for some referrals and inquiries. With system referrals, it's a lot more data than our initial form had. So we are adding to our forms that we'll have in our electronic health record for all of the outcome of the system referral, to make sure that we can get that without our staff having to fill out a paper form. In the meantime, we did make them a paper form to get the outcome of that system referral. We did make a cover sheet and took the state's template for system referrals, modified it a little bit with our logo and a couple extra pointers on it. And it's for that to be distributed to our LPS designated facilities so that we would get good referrals, and those referrals will come directly to our care court team. That just barely got sent out recently so that we can get those system referrals in. The criminal referrals from FIST, MIST, AOT, we were already getting those. They were coming straight into our care court team. They were just putting them on a spreadsheet, but they have to give a lot more data now as system referrals. So they're using our paper form to fill out the outcome of those system referrals until we get our form built in the electronic health record, in which we'll train them. And we've done a lot of communication with them about the data needs that we have. We also made a lot of error reports, or at least my staff did, because she got tired of calling them up all the time. So she made error reports to check for missing data in our monthly check-in forms, and then follows up with them to make sure that they're filling in things that were missing. For a minute there, they started not filling in what was on the care agreement on our form. And so we had to go back and why is there no stuff on your care agreement? Probably will be a data cleaning for us coming up. So we do a lot of checking the data before we're submitting, and used error reports, a lot of communication with the staff that are doing the data, and training. We have some training guides for them as well. We used our clerical staff to help us. They're missing race, ethnicity, or Medi-Cal data or something like that, health insurance. We can easily team message them, tell them what we need, and they do it for us. So that's been working well for us.
That's great. Thanks, Susanna. So it sounds like you really have a whole workflow set up. to really support data collection and reporting, tapping, a broad range of individuals across your team, it sounds like, and working in close coordination with the care court service delivery team. So that's really helpful to hear. The other thing that I picked up on was also the importance of training. While working towards building an EHR, you all are in an interim developing paper forms to support data collection and reporting. So
At least for system referrals, yeah. And we had to get the staff used to this is not optional. You have to fill this out. What the petitions go in right away, and they continue to update the petition process of their court dates and the outcomes of the court dates and that sort of thing, so that we
yeah,
can ensure that they're collecting them, and they've come on board with it. And once you develop a relationship with them and a rapport, that works out pretty well.
wonderful. Yeah, and I also heard about, your error reports, and it sounds like a lot of persistent follow-up to make sure that you're, able to report on the required data elements. So thank you for that. So let's turn to Allison next. Allison.
Hello, I'm Allison Woolley. I'm an ASO with San Luis Obispo County Behavioral Health Justice Services Division. Our workflow is pretty dynamic. I work directly with our forensic FSP team, and I actually process all of our court forms and e-file everything, including facilitating all the demographic data entry when we complete a petition, when we complete a care plan or a care agreement. And because I'm, the admin that produces all that content, it's really seamless for me. I input data as it comes into our system. Currently, we haven't had as many petitions as some of the larger counties have, but when the influx does occur, where we are like truly ramping up and we have, like more than a petition a week, we will be utilizing a tool that I created in Microsoft Forms. It is all clickable and fillable, so there are no data validation issues. There are no type and fill entries unless it's an other response. And that populates into an Excel spreadsheet for me, which I can download through Microsoft Forms and basically drag and drop the data points into the HMA provided spreadsheet. That's been really helpful when workload gets really heavy and I need support from our clinical staff that's engaging with individuals. In terms of tracking our activities for care, I'm also responsible for doing that. So we've been able to collect a significant amount of reimbursement funds. That's been really beneficial. Also using Microsoft Forms, I've created like a time clock where you punch in and punch out. This is integrated with our SAP data. So we have like a time code reference to each care activity. And those time codes are referenced in my Microsoft Forms. And we reference it based on petition number and care activity. And that data populates into an Excel spreadsheet. And I utilize that data to tie with my SAP data and validate that further through our EHR system. We utilize Smart Care, and that EHR enables us to upload all of our care documents that come through the court with a court stamp that kind of validates all of those processes and provides access to, the date the petition was filed, the date that, a report was requested. We also are able to input inquiries into our EHR system, as well as a variety of care activities through notes options. Between the drawdown of data through our EHR and the integration of Microsoft Forms and the very helpful data dictionary that HMA has created, We've been able to integrate data validation into our systems. So when I input data into our Excel spreadsheet from the Microsoft form, each table has a data validation associated with it that's pulling directly from the data dictionary. So if there's an error, it won't populate the data that I copied and pasted. And that kind of helps me manage the data quality. So if it won't populate when I copy and paste, I know that that's, the wrong identifier, and I can go back and fix that before I submit.
Sure. Thanks so much, Allison. It sounds, I heard a couple of things, which is you sound, closer to the care process. It sounds like you're really integrated into how care court operates within your county, touching, different, sort of pieces of the care process. And you've been able to take your understanding of those processes in your county, integrated that into forms that you collect, and also leveraging your EHR system. So you've got, sounds like you're really doing some really good work there. Thank you. So
Yeah, we're very fortunate.
Yeah, no, thank you for sharing. And Paula, go ahead.
Hi, good afternoon, everyone. My name is Perla Vaca from Madera County Behavioral Health. I'm one of the program managers. I oversee 2 data teams for CARE Act, focusing on reporting, and I'm the one who does the QA and oversees that team. Currently, our processes in the workflow, we decided that we were going to be reporting every month, and we utilized the template option B, and we submitted through Move It. That was one of the first things we decided to do when we first went live, and back in December 1st last year. And then what we did was we created a few PDF fillable forms, like for instance, the inquiry, outreach, and engagement forms. That way we were able to make those forms for the clinician and for the case manager to be able to utilize when they were out there for doing any inquiries, any outreach and engagements, or even we utilize those forms for claiming purposes as well, even though it's nothing to do with data collecting, but it's also helpful for claiming. Then once we collect all that information from the CARE Act group, which, like I said, mentioned, it could be the clinician or the case manager or such. Once we collect that data, then it comes to my team. We actually created a timeline log where every time we receive a document, we keep track of it, and then we are making sure that we don't miss anything when we're reporting for the petitioners. We are a small county. During the stages of the process, we just, with those fillable forms that we created and the timeline log that we've been utilizing, has been helping us to be able to compile all the data, which is the data elements are really, really complex. And also we use the data dictionary 2.0 to be able to pretty much make sure that we're collecting all the data where is necessary.
Great, thank you so much. And thank you for highlighting, Paula, that you're a small county. So you're starting small and looking to expand and really sort of test the limits of your existing workflows, and probably that will need to be adjusted over time as well. So thanks for sharing that. So let's move on to the next question. So you all have shared about what your processes are, what it seems to be working well. Wanted to see if you can talk about, not only what has worked well for you, but also where are the opportunities for improvement, right? We know anytime we work with data, we typically hit a snag, and you all get QA reports from us that says, hey, you have to fix something. So I heard some discussion here around how some of you are actually being proactive about doing quality checks. So curious to hear from you all what has worked well, where are the opportunities for improvement? So Matthew, if I could kick it back to you.
Yeah, I would say what has worked well for us about our approach is that um, because of the way we sort of set up our data collection, we're able to access all of the data very quickly. It's updated from the application every morning, and then I'm able to run some sort of automated workflows which both sort of join and process the data, but then also make error reports, and that those that the actual sort of care staff have access to those. Um, but I think on the other hand, a sort of downside of our approach is that getting it updated to the new version of the data dictionary has taken some time uh, because it's, we're doing edits to a sort of live data entry application. So, well, there were some things we could assume about the data when we were building the initial version. We can't necessarily do that now. Like, for instance, when we built the first version of the application, we could assume that all individuals that we were collecting data for had a care petition ID, for example. Whereas now with the pre-petition referral period, we can't. So just getting those sort of updates is taking some time. And had we gone a different route, that getting those changes in place might have been a little quicker. But I still would say that ultimately it is that we made the right choice for our county. Something else I think we've done well is having the sort of care staff involved in, the data analytics side of things when we were going about developing it, making sure it had what they needed. I would still say there's a lot outside of what's sort of collected for submission that they have to keep track of that isn't present in the application. They're keeping track of a lot of things when they're doing outreach and all sort of care work that isn't captured anywhere. So I think in the future, I'd like to have them have sort of a single place they could go to that has everything they need. Yeah.
Gotcha. No, thanks for sharing that. So I mean, it just caught my attention when you said that you're actually collecting data on outreach and engagement in a separate application currently. And so staff are having to manage that in this transition period.
Yes. Yeah, exactly.
Gotcha. Gotcha. Um, all right, let's turn to Susanna.
Thank you. I think what's worked well for us is we did build it into our electronic health record. We do have access directly to the data through a data warehouse so that we could, look at the data, use it for error reports. We also built a Power BI dashboard, and that's been a process, but it also has been very handy because they use it a lot. So if they see something wrong, it'll pull up if something's not entered right. It'll say check this, or they look at the counts a lot in there in terms of the referred petitions, the counts of petitions, and we have quite a lot of other data available in that Power BI dashboard. So our staff use it. They use it for meetings, that kind of thing. So they're not asking us all the time every 5 minutes for a data analysis or something like that. So it's been nice to have direct access to the data and have it direct in our electronic health record. Early on, we created some dummy service codes to bill for activities that they couldn't officially bill Medi-Cal for. And so that since they're doing staff productivity anyway, they write a note and they use the dummy service code. Those are used for us to draw down the funds that we can draw down. But also for us, it just fit nicely when we had to look at outreach and engagement counts for this new data dictionary that we already had it. That worked out well. I think that for system referrals, it did take quite a lot to comb through the 2.0 data dictionary, make changes to the logic and the SQL code of how we were creating the submission file. That took a minute. And then, to kind of sketch out how we had to change that logic. We're still kind of waiting for our system referral form, our electronic one, because our staff are now having to fill out a paper kind of system referral outcome form. So that's been a challenge. We hope to get that improved for them. I think we want to do our own kind of program evaluation report. So we're working on that now, and we also wanted to work with our programs more to give themselves credit for things that they're doing, that they're missing. Like if they do some social service supports and they don't put it on the monthly check-in form, we're not gonna have the data. So we had to explain to them that I went back and looked at a couple of your notes, you're doing some transportation, you're doing some other things that you're not giving yourself credit for. And so we try to work on that some more with them, because there's work they're doing that might not be reflected in the data, and we don't want them to lose that picture of all the rich work that they're doing. So, and hopefully we hope to share some success stories as well in our evaluation reports. That'll be an improvement.
Yeah, no, Suzanne, it's really helpful to hear how you all are using your data, not just for state required reporting, but really you're really trying to leverage the data to give your staff credit, provide insight into the good work that they're doing so they can show it, right?
Yeah.
And, you know, really good to hear how you all are really trying to support your team in understanding the importance and the use of data to support the work that they're doing. So thank you. Allison.
Hi, yes. So I would say successes include just our ability to communicate. Our team meets weekly. We discuss care petitions and processes. That really helps influence my data quality. I am able to maintain a variety of different spreadsheets that kind of speak to our successes outside of the data that we report to you all, including, whether or not an individual has been successfully housed. I'm over the BHBH program data, so have direct access to that. That makes it really helpful. That would be behavioral health bridge housing, to explain that acronym. Yeah, I would say overall, another big success is our cooperative kind of agreement that we have with our courts. We've been integrated into our court systems for the last decade. That has made data validation between our court community and behavioral health a lot easier. We communicate fluidly with them. I work directly with county council and, providing assistance for their data validation and reporting. So across all of our data sets, we're able to, make sure that our data ties. Yep, I would say that the fact that we are so integrated in our mid-sized county, that we all work together and each division communicates really well with one another, has been the best part of this. In terms of moving forward and hopes for like a simpler process in terms of data collection, we're hoping that MHSA, Cal MHSA will finish working on the back end systems for smart care, so that we'll be able to fully integrate all of this data collection into our EHR system. So I will not have to maintain a variety of data platforms. It will all be downloaded in a simple report from the back end of smart care. So that is the goal. Hopefully within the next few months, we'll see something like that happen. So other than that, I'm very appreciative for our clinical staff and the team that we have. It's small, but we work hard and, we get the job done and it feels good.
Great. Thanks so much, Allison. Carla.
Yes, what has been working very well for us is that we have a meeting every month with the court, county council, social services, our CARE Act team, and we discuss options and petitions and what is working well for us, what is not working. So we meet every month, minimum. In the beginning, we were meeting twice a month. Now we're meeting once a month. Then also from that meeting, we also meet with leadership, where are just focusing on CARE Act, also internal with just BHS, and discussing, the petitions, forms, outreach and engagements, and then also meeting with my 2 data teams on a regular basis too, making sure that every time we receive a documentation, we keep records of any outcomes. And then that way we're not just waiting until the last minute where we have to submit the report. Like I mentioned before, we submit our monthly reports, and everything is manual entries. We're not utilizing smart care at this point. And also from transition from data dictionary from 1.0 to 2.0, that really didn't affect us in any given moment because we went live December 1st, 2024, and we didn't get our first petitions until March. So other than that, also we created this guides for the clinicians and also for the case managers. So that way it was just a desk guide to give them an overview of CARE Act, the different phases, the steps, the workflows, the verbiage. We created a whole desk guide for them. Also, we do every quarter, we do a dashboard, and we utilize that for county council. We use that for our meetings with the board supervisors or just anybody that whenever we have a meeting. That way they're also informed of what is happening in our small community. Other than that, like I said, I think the meeting with different other agencies has been very helpful, and also updating and our website, letting the community know about the CARE Act, because I believe that there's still more outreach and engagement that needs to be involved. But other than that, that's what has been working very well for us.
Yeah, so I'm hearing some common themes here about really close collaborations, desk guides and training, and use of data to help communicate and bring everyone on the same page about where things are in the process. So thank you for that. So I know we're, don't have a lot of time, so I'm gonna just do a round robin in reverse just to see if folks have any last words that you want to share. I think folks did talk about our third question. We heard some strategies that you use to QA your data and to support high quality reporting. So just wanted to do one last round robin to see if there are anything else folks would like to add from our panelists. And then we did have a couple of questions that I wanted to make sure we did quickly cover that came in from the audience. So starting back to you, Paula, any last words of wisdom?
I think I did an overview of everything that we're currently doing. I do the QA, my staff, my 2 data teams, they're the ones who are responsible for completing the report, the template B. And then it comes to me, I do the QA, I review the court paperwork, the inquiries, the outreach and engagements to make sure that everything is accurate and it's ready to be submitted. Other than that, like I said, any other counties that would like to reach out to us, let us know. But there's nothing else that I can say. Thank you. I appreciate it.
Yeah, no, thank you. So it's interesting to hear about sort of your more manual process. And, with that, for a small county, that seems to be working well. So thank you.
Yes.
Anyone else? Allison? Anything else to add?
Sure. I would say that, our greatest tool has been not only working together, but integrating trainings. I've created a few visual trainings where I kind of walk through how our systems function. It's really helpful to watch me click through the Microsoft form and facilitate an understanding of how to enter that data. That's been really helpful to our staff. And really integrating an educational tool that kind of goes over what each individual document is that we're filing with the court, where to find dates, where to find outcomes in the information that we're receiving from the court. All of that's been really helpful, and just kind of explaining the law. That's one of my specializations. I'm a master of public policy, so I understand the legislation and analyze that for our team and kind of help communicate how that integrates into their procedures and protocols. So that's been very helpful too.
That's great. Thank you. Susanna?
I think just the new error reports and having my staff even checking more with our care court staff to try to get better and better and not having errors. We hate getting our QA things back, so we're trying to. She's taking it personal now. She really wants a perfect file, and so we're always trying to figure out how to get that a little better. But I think it really, for the QA, you have to check the data and you have to keep on top of it. So she tries to keep on top of it even more now, month to month. And we're going to try to move to monthly, trying to put up a file monthly, just so we're not doing so much towards the end when it's due. I think that will be helpful too.
Gotcha. Appreciate that. And Matthew?
Yeah, I would definitely agree about error reports, and we also have like a missing survey report. But something that has also helped us out a lot is in the sort of design of the data entry tool we use, try to make it as easily as possible for them to not make some common mistakes. So for instance, for petitioned individuals, we have a separate survey for each care status. So they're not, one, filling out questions that they don't need to. And then even within the form, we have display logic. So for instance, like the pad date field wouldn't appear unless they selected was a pad established, and stuff like that has made it, so we don't have to go in and deal with that stuff later. It's just already set up like that. But mistakes happen regardless. So yeah, those missing surveys reports and common error reports are very helpful as well.
Wonderful. Well, thank you all so much for sharing, and appreciate that we only have 10 minutes left. So wanted to turn it over actually to Lauren to see if there were a few questions that were coming up that we could try to answer during the last few minutes. And if we don't get to them, we, as you all know, have a supplemental guide on our website where we post off some of these questions that may not be answered, or we will also utilize future office hours to try to elevate some of these common questions, if you will. So Lauren, I wanted to kick it over to you to try to close us out with questions.
Great. Yeah, so I guess the first thing is I'm noticing a lot of interest in folks wanting to see, especially Susanna and Allison. You mentioned, forms that you've made or developed, and folks are really interested in seeing those. So they have both actually dropped their contact information in the chat. So for folks that haven't seen that, maybe take a look at the chat, and maybe if the panelists are interested, maybe you could just retype in your email address if you are interested in sharing, but it seems like there's a lot of interest in that. In terms of questions, right now I'm tracking two. One we have spoken to a little bit, but I'll pose this to Jessica. The question generally is about smart care data and how it's going to pass through QA when it's really not set up yet for Data Dictionary 2.0 and still won't be for the Q2 data that's due pretty soon. So can you speak to that a little bit?
Yeah, so a smart care report, unfortunately, if just submitted as is, won't be able to pass QA completely, and will have to be corrected before it can be accepted. If any submission is not in alignment with the new data dictionary, it will either be returned for resubmission immediately if the issue is significant. For example, if data dictionary 1.0 template is used, or the individual issues will be flagged as part of the normal QA process. But in terms of smart care specifically, one thing that we have heard from counties using smart care is that they're doing more of a manual manipulation of the smart care reports to better align them with our required template. So I would just say if you're unsure about anything or what might need to be altered in the Smart Care reports to meet our data requirements, feel free to get in touch with us. Sooner the better, just in preparation for this next quarter of data submission.
Great. Thanks, Jessica. And then the other question, I think it's partial question, partial would love to get some group consensus and get everyone talking. It's specifically about large counties. So the question is, can you speak to how large counties are doing in terms of tracking and reporting on aggregate care inquiries, tracking individual level outreach and engagement efforts, and then also tracking changes in care status across months? So I wonder, Serene, if you might be able to kind of speak to that at a high level, Cha also, and then maybe we can open it up to the full group to hear if there are lessons learned around these data elements in particular, folks that have had success, large counties in particular.
Yeah, so this question came in ahead of this webinar here, and we do see that other large counties have been able to report on care inquiries as well as system referrals. I think you heard from a couple of our panelists, Riverside from Susanna in particular, around how they were fortunate in that their system was actually already set up even ahead of the data dictionary revisions. And wanted to invite others or Susanna or anyone else from a large county who may be able to share how you're going about doing this, because we do understand if you don't have those workflows in process, this may be a challenge. So wanted to see if, I think on our panel here we have Matthew, who also represents a large county, or anyone else on this call who might be willing to share some of their successes.
Ultimately, it has to be logged in some format, ideally electronic, where you can pull it from a database and you're not having to have people enter in a spreadsheet. That's usually miserable. I think our biggest challenge probably was trying to get the subject of the inquiry. Sometimes it's in a note, and so my staff spends a little bit of time figuring that out. Some of it we were able to tackle in SQL queries, but ultimately you have to log it. Somebody has to record it. There's really no other way around that, I don't think.
Anyone else, or the county or whoever who asked that question, I think you may know who you are. If you wanted to follow up with any questions based on the response so far.
Thanks for teeing that up. I had a follow-up question for Susanna. We're coming for you, by the way, and we've been meaning to connect, and we really need to. But do you have like one application that kind of tracks all inquiries about services, period?
It
or
is.
unique?
It's in the electronic health record. It's something called a communication log, and it's
Right.
existing clients with an ID. If there's a random one where there's not a client ID and they're not going to create a client ID, then they do have a log, a call log that the access line has always used. So we just pull
Yeah.
from those two places, and that it's in a SQL backend, so we're not having to do anything weird to pull it out. And because the way the field values are set up, for me to be able to pull the specific care
Yeah.
court inquiries. So we're not having to do a lot of work to do that. It's early on, we made sure that value was there for us to differentiate the log entries.
Yeah, I think that's our challenge, is kind of unifying all of these different places where the information might come in, right? So there might be direct requests to the care team that they kind of keep in their own log, Excel sheet, something like that.
Yeah.
And then we can tap our phone line, I think. And if it's more about where the client gets referred to more than what they're asking about. So then that becomes the issue about like,
It is tricky for
yeah,
when you have a lot of stuff coming in. We tried to encourage all of our inquiries to channel through our CARES access line. So they got
yeah,
very few calls direct to the care court team. And if they did,
gotcha.
it was a full-on, they filled out an integrated referral for themselves because it was deep enough at that point. And then the systems were trying to differentiate them. Look, you're going to get those system referrals and you're going to enter them in this form, so that because those are deeper And those are the ones we expect more to come straight to our team. They didn't want them to have to field so many calls all the time. So we try to kind of channel them in the 2 channels.
Not sure if anyone else on our panelists or anyone else would want to, I know I'm cognizant that we have 2 minutes, and if this is a topic that would be, that folks would be interested in pursuing, because we know, these are new sections of the data dictionary. We do see some challenges, and I think we did see some comments about whether or not this is really truly no inquiries or it's more of a system and data collection issue. So really try, so let us know, feel free to drop in the chat or drop us a line to, let us know what would be helpful to you all as you're grappling with, how to best collect this data, harness it for your different purposes, including state reporting. So with that, I don't see, Lauren, do you see anyone else coming up mute who might want to jump in?
Nope, no more questions in the chat or my direct messages, so.
Okay, wonderful. So I know we're coming up on time. I'm going to kick it over to Carly to close us out.
Yes, sorry, I was on mute. I'm just going to give a plug for our data collection reporting resources page, link in chat right there. Also, the conversation doesn't have to stop here. We have bi-weekly data collection reporting office hours on Wednesdays. We bring some guidance to those conversations, to those office hours, but also welcome you all to bring discussion items or things you'd like to brainstorm around to those office hours. Additionally, we have other opportunities to access technical assistance through our technical assistance reporting or form here. We also recommend that data team members sign up for the listserv to make sure you get communications from us about trainings, as well as instructions and guidance for reporting. A couple other pieces of information here that I'll put in chat. But that's all we had for you. Another plug for our email, caredatateam@healthmanagement.com. If you have any questions at all or want to follow up about anything that we've presented here, please send them that way. Thank you all so much.